Hello, everyone. It is my distinct honor to welcome good friend and our speaker, Dr. Macey Levan, and she will be talking about xenotransplantation today. Welcome, Macey. We're so glad to have you.
Thank you so much, Melissa. Let me share my screen. And so today, we're going to talk about the future of xenotransplantation. And as Melissa said, I'm Macey Levan. I am an associate professor at NYU Langone Health in the Department of Surgery, and I direct qualitative research for our Center for Surgical and Transplant Applied Research. I'm very excited to speak with you all today, and thank you for being here. So what is xenotransplantation? I assume everyone here probably already knows about it because of what I'm showing you here. Every major news outlet that I have can think of has published stories about these medical milestones that we have been making over the past several years in the United States with transplanting pig kidneys and pig hearts into living human beings and deceased individuals. Um, the media attention is probably one of the reasons why we're pushing forward so fast, because people are knowing about this and acceptance is relatively high. So what exactly is xenotransplantation? The official definition is that it's any procedure that would bring a live cell, tissue, or organ from a non-human animal source, such as a pig, into a human. It also can be in the ex vivo context. And so there's different ways you can think about it. But for everybody on this call, I would assume that the best way to think about this is that it's a pig organ into a human being, whether they are deceased or whether they are living. We have done it both ways. So the history of xenotransplantation is pretty it's gone on for a while. We've seen all these recent news stories where we've just done genetically modified pig transplants into living recipients, and we had hearts done previously. But this has been going on since the 1600s, back when they were doing sheep to human blood transfusions. In the first documented solid organ xenotransplants were in the 1920s. We moved to some chimpanzee kidneys that were transplanted to 6 humans in 1963. And in 64, we did the chimp heart into a human. So a lot of you probably know about baby Faye. That was in 84, the year the National Organ Transplant Act was passed. And so we've kind of been moving along since then, but it wasn't until 2021 when we were doing the first pig to human decedent transplant. So these genetically modified pigs were utilized in a human being that had already received a brain death diagnosis and was not able to donate organs for transplantation or tissue for research because of some other reason, commonly a malignancy or some other thing. So their families said yes to donation. And in these cases, these very brave families inspired decedent research in the context of xenotransplantation. Our milestone at NYU Langone Health in a brain dead human was 61 days. That was a very interesting experience to witness, and it's a very exciting time for medical miracles, if you will, in modern medicine. But why are we studying xenotransplantation? It's pretty simple math. The organ shortage cannot be solved with deceased and living donors alone. No matter how much we promote or discuss opportunities for advancing deceased donor transplants and living donor transplants, it seems like the wait list will continue to grow while the supply will never catch up. And that is why xenotransplantation is being studied, particularly when you see a wait list of almost 90,000 people that need kidneys. It's a very big pool of people who could benefit from this science. And so that's our rationale for why it's important. And so what you are hearing most about right now is xenotransplantation with pigs. And the reasons why you're hearing about it with pigs and the reasons why we're choosing to use pigs in these experiments are that pigs and humans have been living in proximity for many years, and there's a lot of good potential for breeding. It's a widely available source. Importantly, particularly for children moving forward, kidneys, the size of organs really matter, and we know that. And so kidneys from a pig are very similar in size and structure as human kidneys. And we have also done so much work with zoonosis, which is the transmission of infectious disease from animal to human, that we have reduced the risk of disease transmission through the with using the pigs. A lot of the experience with genetic modification has made these pig organs more compatible with our human immune systems. So that helps reduce infection risk in general. And also from an ethics perspective, it's really important to remember that there are over 100 million pigs that are bred for food annually in the United States. So while I am certainly sympathetic to animal rights and activism in this way, weighing all of the options, pigs seem to be a feasible and ethical and viable source to move forward with xenotransplantation in humans. You might ask why we can't just do this in animals. The pig to non-human primate model, so when I was speaking about some of the baboon hearts, they've been common for a long time. And it does allow us to learn about the best genetic modifications that we'll want to use in xenotransplantation, as well as medications that we use to ensure that the graft, so the organ, is successfully transplanted into the individual without rejection. But animal studies may not be enough. And while there is a lot of research in baboons, there is a limitation to this model. And we do need to understand a lot more before we move clinical transplantation trials with living patients. And so that's one of the reasons we've done some of these decedent models where you're doing a xenotransplant in a brain death individual. And the questions we really need to learn and answer are: immunosuppression medications are key here. What are the outcomes that we're going to see with what we do? And what types of genetic edits are required in that donor pig so we can prevent rejection and make sure that the human who receives the transplant has good organ function? We also are trying to learn how the human immune system will respond to pig organs. And does that pig kidney, once it's transplanted, maintain a normal function in the human? So does it filter urine and manage blood pressure and do all of the things that we know that the kidney needs to do in the human body in a healthy person so that they do not have to be on dialysis? So how do we move from these animal models into clinical trials involving humans? First, they've had to do a lot of research into what the public thinks about this, as well as what patients think about this. And groups other than ours have done this. We also have a lot of our own research that is forthcoming in the public education space. And in summary, most of the science to date has been very supportive of advancing these trials and advancing the conversation around how to support a system where we actually can implement xenotransplantation once it proves safe and effective in the best possible way. Because as everyone understands, transplantation is a treatment. It is not a cure. So people that receive transplants still have challenges and lots of different types of outcomes. So we're not trying to say that you get a pig kidney and you're cured, but that do those outcomes, are they comparable with those from a human transplant? And so far, most of the public perception is really wanting to know more information and hoping that we can start trials. Very importantly, the National Kidney Foundation held a patient-facing summit in November of last year. And while they were focused on trying to explain what patients might want to see in clinical trials, the main push was to get the FDA to try to advance this, because the scientists are ready, we're ready, we're just waiting on the regulatory structure to support the research in this space. But what has happened that you have seen so far is that the FDA has given approval to use investigational organs. So these pig organs are considered an investigational organ for living patients through what we call their expanded access program, compassionate use. Can we do something because someone else is never going to have a chance to survive otherwise? And will they grant these exemption cases to hospitals and the healthcare teams and the patients that are making these requests? And so this has happened so far in the United States 4 times. The first case was at the University of Maryland in January of 2022, where they transplanted a pig to human heart in a man who would not be able to survive without participating in the experiment. And he ultimately did pass away, but he was a very brave person to say yes to such a trial, such an opportunity for a research experiment. The next case that we saw was again at the University of Maryland, and they tried it again. And then in March, very recently, the news showed a great story that our colleagues at Massachusetts General Hospital were able to transplant a pig kidney into a man who was having difficulty with dialysis. So that was one of the reasons that the FDA said yes. And you may have seen news that came out of our hospital a few days ago, where we did a combined LVAD and pig to human kidney transplant in a woman who otherwise had weeks to days to live. And it is still very early in that case, but I think we're 12 days out as of today. So it's an exciting time, but the reason we've been able to do it so far is because of the investigational process through expanded access. That is not a clinical trial. These are individual petitions that we've had to make to have these cases occur. Here's just some pictures of the cases in Maryland, the first ones. I live in the state of Maryland, so I thought this was pretty cool. A Maryland man got the world's first pig heart transplant, and very brave. And then the second transplant, I think that made news as well. And then most recently, one of our greatest, I think, medical milestones here is that we were able to send home a patient who received a kidney. This was our colleagues at Mass General, and Richard Slayman doesn't have to be on dialysis right now, although he's getting a lot of monitoring from this transplant. This is sort of a really, really exciting step, and we're still waiting to hear how he does and more information about that. And then recently, 12 days ago, Lisa, one of our patients at NYU, participated in another landmark procedure where we combined the xeno kidney that you see here with an LVAD placement. I know a lot of you are heart transplants caregivers and community members. And so you kind of, I'm sure, have a very good understanding that an LVAD placement is a big deal. And so we did both of these at the same time. And so we're 12 days out from that, and she's doing good today. And I think we'll just continue to take everything day by day. But the fact that we were able to do the LVAD and the kidney at the same time is another step towards understanding what type of clinical trials will we be able to design and what people should be eligible for them and how we will do that. So going back to this single patient expanded access, I just wanted to make sure everybody was on the same page, because this is kind of the only way it's happened so far. They have to have a serious life-threatening condition, and the patient is unable to qualify for any alternative medical treatment. So in the case of the kidney patient at Mass General, he was having difficulty with his dialysis and wasn't able to have quality and dialysis treatments in a way that would probably prolong his life. And instead, the dialysis could have been continuing to pose a danger to him. At least that's what the news was reporting. So the FDA said yes, which was fantastic. And then the same thing with the LVAD case is that the woman who received the pig kidney and the LVAD did not have any alternative medical treatments available to her at the time. And so we had to file what we call an investigational new drug application to the FDA that outlines the intended treatment protocol, justification for why the patient is not a candidate for standard of care medical treatment. And then the FDA will either approve or deny that. In these cases I've talked about, they have approved it. And the protocol, and the protocol and consent documents that we provide patients also have to be approved by our institutional IRB. So the Institutional Review Board is a requirement for the conduct of research with humans and animals. And there's a lot of approvals that have to happen to enable a single patient to receive a transplant under these circumstances. So what have we learned as researchers from xenotransplantation so far? We've learned, and what are we learning as we speak? Is it safe? We are doing a lot of infectious disease surveillance for pig viruses. So zoonosis is a really important consideration that has the opportunity to kind of create problems for not only the recipient, but those around the recipient. And so that's a huge consideration that teams have paid very close attention to. And so we have not seen any transmission of pig viruses to any human to date in our living or deceased cases that I'm aware of. And so what are we studying when we're looking at these cases? We're studying to see the function of the organ. So does the kidney and the heart, in our case here, and other organ systems, how do they work in the body? Does the body accept the organ? What is that risk of rejection? And what are the best medications to use to prevent rejection in the case where you would receive a pig organ? So everyone's asking, does it work? Does it work? Well, like I said, we have done this in a few patients. And so all we can speak to are these case studies and early studies and clinical experience. The organs have immediately functioned, which shows promising results. And there have been cases, though, where the body rejects the organ and treatment of the rejection is required. This is no different than in cases of a human transplant. So while we are learning lessons, many more studies need to happen so that we can continue to really understand long-term outcomes of xenotransplantation in living humans. And that is where clinical trials ultimately will come in, where we can enroll multiple people with set inclusion criteria and study the function of the organ and study the rejection risk and study medications to prevent these rejection risks. So how do we get there? How do we get to clinical trials and making this a reality? Additional preclinical research in animals and decedent models is really important. That is research that we are doing at NYU Langone and other places around the country. I believe are really working towards trying to do decedent research. So people who are unable to donate organs for transplantation for many reasons may be eligible, if they are declared brain dead, to participate in deceased research studies. This is not just for xenotransplantation. There's other reasons why we would do research in the deceased. But for our purposes of xenotransplantation, it's very critical because we can see do long-term studies and study things in different ways than we might be able to in living humans. We have to submit applications to the FDA, just like for compassionate use. We have to submit applications for clinical trials. And so that is all in process, and everyone's really working hard to make that happen. And we can still, while we're working on getting to clinical trials and doing these decedent studies, we can still file applications for these emergency use cases in patients who are ineligible to receive human organs or who have no alternatives in the cases that have made the news in the most recent past. So while we wait for clinical trials to begin, let's think ahead about what this means for pediatric patients. So I want to talk with you about research with pediatric patients and children, which are considered a vulnerable population, along with prisoners and pregnant women, according to federal research guidelines in the United States. There's a lot of ethical considerations and these federal regulations, which are important for us to consider and manage while we plan and prepare for any potential trials for pediatric patients. In any case, in any research study, whether it's for this or something much simpler, it will require that the parent or caregiver or legal guardian provides consent because the child is under 18, as well as what we call assent. And that means that a patient over the age of 7 can talk to a researcher and say, yes, I agree to do something like this. So it's not just the parent making the decision. We need to see that the child is also willing to participate at a certain age. There's also some recruitment challenges involved in pediatric research, primarily because of the strict nature of federal regulations and getting all of this done. It takes a lot of time, so it's very difficult, and there's a lot of red tape, if you will, to get patients enrolled in pediatric trials. But it happens a lot, and we do it in lots of spaces, and so there's no one shying away from that challenge, but it does exist. We need specialized expertise, including those with lived experience, such as caregivers and families, to weigh in on how we design these trials, and what is required for people who participate in them. As one example, there's a current kind of ethical consensus that recipients of xenografts, so if you get a pig organ, you need to consent to lifelong monitoring. So the patients would need to be available and willing to come to the transplant center or do in-home monitoring, which is, I think, a really great idea. And in-home surveillance, we have so much technology today that we can do a lot more while getting people out of the hospital and back living in their lives. But that they would need to consent to lifelong monitoring. And really, what does that entail and what does that mean? That's an open kind of thing. And then this presents some challenges with an ethical principle of the right to withdraw from a research study. So it's a voluntary process. And if you're a research subject, you can say, hey, I don't want to be in this study anymore. But what does that mean if we put a pig kidney in you and we require that you consent to lifelong monitoring? That becomes even more difficult in the pediatric population when you're dealing with the need to consent and provide assent from the patient to do these types of things. What does that mean for their life? What does that mean for the people that they're around, their family, their friends, their school, their social environment? What type of kids could even be considered to participate in these trials? And so, as I mentioned, there are federal regulations that we have to abide by when doing research with human beings. And research with children, as they are a vulnerable population, is classified into 4 different categories based on the level of risk and potential benefit to that patient. There's 4 categories. The one is, research not involving greater than minimal risk. And that is like your survey study, your interview study, your focus groups, things when people like me who are qualitative researchers ask questions and ask you to think about things. Usually minimal risk means that you might lose your confidentiality by participating in a focus group. Someone might know who you are, or that might be the most risk you're having, is that risk of potential loss of confidentiality. And that's really no greater than minimal risk. But then there's these other categories that a lot of other research fits into: intervention trials, pharmaceutical trials. This is pretty common in oncological studies. So research that involves greater than minimal risk, but it presents the prospect of direct benefit to individual participants. So institutional review boards will allow this research with proper justification. They will also allow research that involves greater than minimal risk and no prospect of direct benefit to the participant, but it would likely yield generalizable knowledge about that condition the participant has. So this is when you're talking about potentially terminal illness cases, when you have clinical trials of drugs, where this might be, we can't say that it's going to benefit that patient, but it may yield scientific knowledge that could save the people that are coming behind them who might suffer from the same condition. And then in the same vein, research that is not otherwise approvable, which presents an opportunity to really understand, prevent, or alleviate a serious problem affecting the health or welfare of children. And I think that we'll have to really think carefully about how we present xenotransplant research in children to institutional review boards, understanding that these categories are there. There is a consensus statement about heart transplantation in children, xenotransplantation. And a lot of experts got together and thought through this pretty intensely and published this in the Journal of Cardiothoracic Surgery. And the central message of their consensus statement are that neonates and infants with congenital heart disease may actually benefit from heart xenotransplantation. But that obviously successful clinical translation of this model requires the utmost ethical scrutiny. So we have to do a lot of work to figure out some of the details before clinical trials would begin. But it seems like kids that may not have another option would be the right kids to start these trials with. And in heart transplantation, the littlest ones who are born with, I believe, half a heart or another condition are greatly limited by not only the shortage of donor hearts, but by their size. So you can't put an adult-sized heart into an infant. And so there's not a lot of babies that die in a way that allows them to be heart transplant recipients, donors. And is this a place where pig hearts could be used as a bridge to heart transplantation in these patients? That's a kind of a big question we have right now. And so I wanted to take the rest of our time together to have you help me help the community shape the future of xenotransplantation clinical trials for children, to kind of see your thoughts and see where you think we should go and what concerns might have. So we have prepared a couple of polls for you. Melissa, can you run the first poll? And the first one is, how familiar are you with the concept of xenotransplantation in general? I know I gave you a good overview of this, but just go ahead and answer that now, please.
Poll has been launched and participating now.
You want to go to the next question? Oop, we're still getting a response coming.
Word.
Do I need to end the poll, Melissa, or is that something you would?
I can absolutely do that.
Okay.
Okay, so I
We'll
will go
to,
ahead and end.
yeah,
the
let's
next
end that and go to the next question. Okay.
poll, and then I will share the next poll. One moment. There we go.
Okay, let's play a game of would you rather. Would you rather have your child on dialysis for 3 years before receiving an allo transplant, so a human transplant, or participate in a clinical trial for a kidney xenograft? The caveat here is that dialysis would be an option if the organ failed. Would you rather, if pig kidneys are proven safe in adults, would you enroll your child in a clinical trial to assess the safety of a pig kidney in children? And if safety with pig heart transplants was demonstrated in adults, would you be willing to enroll your status 1A child in a clinical trial to receive a pig heart transplant? Poll is running.
Hello, everyone. This is Melissa McQueen, and thank you for your patience today. I mean, it was such a great presentation. We will go ahead and finish up the poll here shortly. We will get all of your questions answered, I promise. We'll send them to Dr. Levan for commentary after the fact. But thank you. Thank you for your patience with us today. We appreciate it greatly. We will end this poll in a moment so that you can join the other sessions in progress right now. Thank you, Dr. Levan, so much. And let us know. We will actually be doing a follow-up to this. We appreciate your time greatly. I'm going to end the poll now and share the results. And with that, I will say thank you. Thank you so much for being with us today. We appreciate it.
Absolutely. My pleasure. Thank you for having me.
Anytime. We hope to have you back.